Hi, good morning, everyone. Welcome on in the first session of the March. We are sitting on 9th of March, 9:30 a.m. Indian Standard Time. And we have a very important topic, lupus nephritis. To discuss about this topic, we have Dr. Ratan Jha. He's a senior nephrologist and transplant physician at Care Hospital Outpatient Center, Bajrang Hills, Hyderabad. Dr. Jha has worked as a nephrologist and DNB training teacher for the last 3 decades and is considered to be the best nephrology doctor in Hyderabad. He has also been invited as a faculty for many conferences. He has been NBE Delhi examiner for nephro super specialty for several years. He has been author for multiple book chapters and participated in various clinical drugs trials in nephrology. So we welcome you for enlightening us for this topic, and over to you.
Good morning to all of you who are in India or in the Southeast Asia, and maybe good evening for those who are in the Western zone. I have chosen a topic of my interest, the lupus nephritis, which is a disease difficult to treat, requires treatment for a long time. But I am trying to confine myself to few areas of what is new in this disease so far treatment is concerned. Not moving.
Do you need to click the slide or the arrow button?
Yes.
Yeah. Perfect.
We are all aware of the fact that SLE, which is also called in medical terms as lupus, is not uncommon anymore. We in India are seeing this disease of late quite frequently, which was not a case when I was an MBBS student, say 30 years back, or maybe the MD student. That time we used to see less often, which is pointing to the fact that probably there is an environmental change which is increasing the incidence of this autoimmune disease. Besides the investigation facilities for making a diagnosis early, it is reported that it affects 1 in about 1,000 people in UK, and the prevalence in US, which is estimated to be 15 to 50 per lakh. That is to say that it is a common autoimmune disease in the recent times. And despite improvement in the survival over the last 4 decades, the lupus patient still die on average 25 years earlier compared to their other counterparts, both male and female, as reported in the UK data. It is a disease which is punctuated by flares and disease exacerbation of varying severity, which requires therapy with the consequences of immunosuppression-related morbidity worsening. Flares in SLE patients therefore incur significant clinical financial burden to the patient and needs many times exclusion of mimetics, because many times infections have a similar kind of presentation as we see flares in SLE patient, and hence it requires a diagnosis which has to be precise. SLE, we know, affects multiple organs, and hence it can be seen by different specialists at different times. It is an autoimmune disease, but has a heterogeneous kind of presentation. It affects different organ systems, including skin, joints, central nervous system, cardiovascular system, respiratory system, and the kidneys. And hence, all the specialists of in the medical fields may be involved during the diagnosis, management in its entirety in the patient's life. Organ damage as a consequence of disease is expected, but the long-term use of some of the treatments are also key determinants for the patient's quality of life. Damage in SLE, therefore, is not only related to disease activity, but also because of the treatment. Hence, we are discussing what is new in this area. So, when we look at lupus nephritis, when we talk about what is new in the area, is there anything new in the armamentarium or diagnosis? Is there anything new in the treatment domain? And are there any new biomarkers which have been propagated for making a diagnosis early for the disease or for the disease activity. We are aware of the fact that there are many unmet medical needs, and one of them is that the clinical characteristic of patient who may not respond to the current standard of care is still not well defined. We do not know. We give the same treatment, few people respond and few do not respond. We are not having any kind of clinical kind of characteristic which can define that this person may not respond. There are certain specific situations like childhood onset lupus nephritis, antiphospholipid antibody syndrome, or membranous, whether they have to be treated anyway different from the common garden variety of glomerular disease related lupus nephritis is still a point of research, because we treat many of the disease in a similar manner. So the unmet need or the futuristic idea that I see in this domain is that we are looking for precision medicine, which should like matching a given drug to the most responsive disease phenotype. That will be the future of lupus nephritis. For example, anifrolumab in SLE patients was reported to have a best kind of response in people who have high interferon signature. That is a kind of interferon alpha is levels are higher in such patients. They respond best to this drug. So we are now looking at the precision medicine, but it's still far from reality. Emerging therapy at this point of time in lupus nephritis is focusing mainly on induction agent. That is what is the agent to be given in the beginning of disease control, but the less on maintenance therapy, because that is the area which is still very few drugs are being talked about in SLE. Specific situations and subset like childhood SLE, male SLE, related SLE is still not treated anyway different, and we are looking for some futuristic ideas in this regard. So coming back to lupus nephritis, it is a disease which develops in almost 40 to 60% of patients over time who are followed up with SLE. Preventing kidney damage in SLE has a long-term prognostic implication, because this is the one of the commonest thing which ultimately leads to a poor quality of life and many times a mortality. Currently, the standard of care, which is corticosteroid plus other immunosuppressant in different combination, which has improved the survival over time in last 4 decades from 17% at 5 years to 80% in those treated. Though the burden of drug toxicity is also seen with this kind of therapy. It has been reported that 10 to 30% of patients who are followed up with for lupus nephritis develop kidney failure within 15 years. The term kidney failure means they require dialysis, a dialysis-dependent kidney failure. So when we look at in a simple way, what is the impact of SLE on kidney disease? Lupus nephritis is considered to be one of the frequent and serious complications of SLE patients. It develops early. It develops within 5 years in most of the patients after the SLE diagnosis. The incidence of lupus nephritis is around in 10 years time, the patients who develop lupus nephritis, 4% will develop end-stage renal failure. But if you're looking at the only lupus nephritis patient in the follow-up, 10% will develop it over 10 years. The lupus nephritis is associated with threefold increased risk of death, and it's not only because of disease of kidney disease, but because of the treatment of kidney disease, infections, and other cardiovascular events. Beyond, if you look at the end-stage renal failure, it has been reported that up to 30% of patients of SLE will ultimately develop kidney failure if they live long enough. The diagnosis of SLE over time has changed, and earlier we were relying more on the American College of Rheumatology 1997 criteria, where 4 of the 11 clinical or a lab criteria was to be satisfied. But over time, the SLIC criteria, that is the Systemic Lupus International Collaborative Clinics 2012 and ACR-ULR criteria 2017 has developed, which has having a 7 domain, and the 1 domain which is constitutional domain of fever has been added in the latest criteria, which is given a point, and based on those points, people are classified to develop cluster to have a diagnosis of SLE. And one of the basic criteria for all these things is that patients should have at least an ANA based on the immunofluorescence and the titer of 1:80 before, and the clinical support to make a diagnosis of SLE. So this is the diagnostic area which has changed over time, and still the same thing is being utilized to make a diagnosis for SLE or for the exacerbation of SLE in the follow-up when the disease comes with a bang. So the lupus is diagnosed, or even the flare of lupus after the remission is diagnosed based on these criteria of combination of symptoms, signs, and tests. For diagnosis of lupus based on the criteria is that we should have an ANA positivity and a score of 10 based on the latest criteria. ANA positivity should be more than 1:80 titer, and 10 points in the latest 2017 SLIC criteria should be there, or the ULR criteria. In case the points are less, it is called an undifferentiated syndrome, and it has to be followed up for a time to understand whether things are evolving. Flare of SLE after the disease has become quiescent or has decreased is diagnosed by the increased activity in more than one domain. That we have talked about, that there are 7 domains of making a diagnosis of the SLE, clinical domains. At least there should be increased activity in more than one domain. For example, kidney domain and skin domain. 2 domains, if there are increase in activity of symptoms or signs, that means the disease has come back. So the combination of symptoms and signs and tests is important to make a diagnosis of SLE. Which can be any kind of criteria can be utilized based on the remembrance that symptoms and signs based on ACR 97 or SLIC 12 or ULR 17. All of them have been validated. We use ULR criteria to make a diagnosis of SLE. Lab evidence of NA positivity of more than 180 is very important. And if it is associated with increased double-stranded DNA and low C3C4 activity, it is a kind of marker of disease activity and the flare in the follow-up. We need to have an appropriate biopsy evidence, like a renal biopsy or skin biopsy as may be required, or a radiological evidence of a damage in the form of X-ray, CT scan, and MRI to supplement the diagnosis of SLE disease activity or a complication of disease therapy. But one has to remember that there's hardly any kind of category where ANA negative lupus is talked about. That was a earlier kind of description of 95% being ANA positive and 5% could be ANA negative. But a patient who is treated for SLE, the ANA negativity could be seen as shown in the slide. One of the common reasons for ANA negativity could be the patient has gone into remission. That is one of the reasons for ANA negative in a patient of SLE in the follow-up. Though anti-B cell therapy like rituximab, or a patient who is on dialysis they may have an ANA negativity. There are other reasons which I mentioned, like person having heavy proteinuria antibody may be lost, or there are other kinds of SLEs where the markers are not nuclear, it is in the cytoplasmic domain, or titers are too low to be picked up. So American College of Rheumatology has given these 7 reasons when you may have an ANA negativity in lupus, and you should not feel that that may be the only reason to exclude the disease. But that is one of the basic criteria to making a diagnosis in an appropriate setting. The diagnosing a flare in SLE after the disease has been treated is always perplexing because the disease is multi-systemic in nature, and the signs and symptoms which are seen in the flare have very low or very at the most modest specificity for its association. So it should be always discriminated from other conditions such as infections and drugs or toxicity before we make a diagnosis of a lupus flare in a patient who has been treated for the disease with standard of care. The burden of flare in this disease is quite high, and it has been reported that within 1 to 2 years after the patient has been treated with getting into remission, 20 to 25% of people may have a kind of rebound of the same kind of domain activity. And 40 to 66% of patients can develop this disease over 5 to 10 years as a flare, etc. And it has been reported that 70 to 80% of flares are only mild or moderate than that. So any kind of things are seen in can be seen in a patient of lupus disease, and hence it is a disease of variable kind of presentation, and that's why it mimics many kinds of disease which is difficult to many times exclude, and that requires a kind of clinical acumen to decide how far to go with what investigation and what treatment. So in this regard, when we are looking at the disease flare, we were looking at various biomarkers, and we're looking still at emerging biomarkers. The traditional biomarker is anti-double-stranded DNA. When it is high, we consider that the symptoms could be because of the lupus flare. But there are many other emerging kind of biomarkers which are shown in the slide. The ALCAM, that is adhesion molecule, leukocyte adhesion molecule, which is also emerging as a very important biomarker. CD16, IgG, and many other biomarkers are mentioned in the slide, MCSF and NGAL, but they are not yet emerged as a tool to make a diagnosis, but it is being explored in the research domain. The three traditional biomarkers which are utilized in our day-to-day practice is anti-double strand DNA, complement level low, and C3 and C4. And this is linked to an increased disease activity. But the emerging biomarker that we talked about, that activated leukocyte adhesion molecule, is the ALCAM, is NGAL, VCAM, is also being utilized in research domains to see whether the combination of things can make a better diagnosis of lupus flare. So when we see a patient with SLE as a clinician, we need to always categorize the disease, because the category will decide how intense the immunosuppression or intensity of immunosuppression has to be there. Disease activity is categorized into mild, moderate, and severe during a diagnosis and even during the flares. Mild disease activity is a disease activity where patient looks clinically stable with no life-threatening organ involvement and manifesting mainly as joint disease or arthritis or mucocutaneous lesions or mild pleuritis. Patients with moderate disease activity have more serious manifestations. And severe disease activity is defined as organ or life-threatening disease where person has a kind of, which requires an ICU admission. For example, a patient with respiratory failure and having severe lung disease with, or as RPGN, where the patient is having rapidly progressive renal failure and last 2 years, like this is a female patient who was a class 5 lupus in total remission and had gone for a pregnancy as per the planned pregnancy. And as during the pregnancy, as she had some bleed, patient was put on hormonal therapy. Following the hormonal therapy, there was a disease this activation, so post hormonal therapy, moderate flare during pregnancy, and it required a methylprednisolone therapy in low dose to control the disease activity, and patient had a kind of uncomplicated delivery. This can happen in a situation where the disease is quite inactive, and suddenly with addition of one therapy, that the disease can become active. This was again a patient who was planning pregnancy, withdrew the drugs like MMF that was getting, and steroid was reduced to the lowest dose. And what was happened that within 2 to 3 months, patient came with breathlessness, and what we see in the X-ray chest as well as CT scan is a large amount of pericardial effusion, which was initially construed as possibly tubercular, but it was a disease activity of lupus nephritis, and patient ultimately received methylprednisolone with MMF with improvement in the general condition. The patient in the follow-up for last 6 months without any problem. So the disease can suddenly become active, the drug is discontinued. That is the message from this 2 cases that I wanted to show you. This is a patient postpartum presenting after the cesarean section with acute breathlessness and admitted in cardiology ward, thinking that this patient is having a kind of pneumonia. What we see in the X-ray chest is a kind of vase-shaped opacity, which was a kind of pulmonary infarct, which is supported by CT scan, which was due to undiagnosed SLE with Apla syndrome, which was treated subsequently. So this is just a CT scan of the same patient. What we see in the CT scan, the left side of the kidney is visualized with the contrast, while the right side kidney is looking black, or that is an infarcted kidney with a thrombus in the inferior vena cava. So inferior vena cava thrombus presenting with pulmonary thromboembolism post cesarean section, mimicking like a pneumonia, but it was a pulmonary thromboembolism associated with Apla syndrome and SLE postpartum. So the disease is common in females. The 3 patients that I showed, all of them were female. So SLE is a disease of females usually, and it is believed that hormone, particularly the estrogen, has something to do with the increased kind of disposition. So there are many other kind of reasons why it is more common in females, but it can be seen in males as well. So this is just to highlight the point that when we see a patient with a complicated course and complicated kind of expectation, we need to categorize the patient into mild, moderate, and severe. And based on that, the initial therapy could be either form of local therapy or simple therapy like SCQ or methotrexate in mild disease. And in a case of severe disease, which is to be always properly assessed, where higher dose of prednisolone with azathioprine, MMF, or cyclophosphamide may be required. So this is a nice guideline, which is quite nice to use in our day-to-day practice. So as a nephrologist, when we see a patient in the follow-up, there's a kind of abnormality in the report, we try to talk about renal flare as two categories of renal flare, which is a proteinuric flare where the proteinuria increases, and the proteinuria increase is said to be quantified as proteinuria more than 2 grams with no hematuria. And nephrotic flare is based on the presence of increased number of RBC with change in the creatinine from the baseline by more than 30%. The nephrotic flare or a proteinuric flare may be treated a bit differently depending on the histology, but that has to be always followed up to decide whether treatment is making a difference or not. So that when we try to treat, we treat to target, etc. That is the approach for any kind of disease which requires a long-term therapy. And when we are trying to treat SLE patient, we should not only treat the organ, etc. We should ensure the long-term survival. We should prevent organ damage and optimize the patient's quality of life by looking at the drug toxicity and comorbidities. In this regard, the definition of remission, the Doris Task Force has defined various kind of things to make the clinician comfortable to decide which kind of therapy is required. The critical domains which is under the consideration for Doris Task Force has been clinical disease activity, surgical activity, duration, and treatment. Remission is defined as absence of major symptoms and signs of SLE that we talked about in the EULAR criteria. There's a term called remission on therapy where patient is having some abnormality in the urine report or blood report, but patient is not having any clinical signs and symptoms of disease activity on low dose corticosteroid. So there is a term which is called serologically active and clinically quiescent SLE, where a person has to be followed up more closely to decide when to increase the dose of immunosuppression. So there are various facets of treatment in a patient of SLE which has to be appropriately understood. So in this regard, the KDIGO, that is the Kidney Disease Improving Global Outcome 2024, has given practice guidelines for lupus nephritis, it is a kind of visual abstract to summarize the findings. We said that when you make a diagnosis of lupus nephritis, biopsy is required only when patient is stable with a proteinuria more than 1500 gram per day, or patient has active urinary sediment in the form of presence of RBC with cast or decreasing eGFR. So there has to be, if a patient has a proteinuria less than 500 gram, it may not require a biopsy. The general measures have to be employed in all categories of patients, like using the hydroxychloroquine unless it is contraindicated, looking at the cardiovascular risk and delaying the cardiovascular risk and delaying the CKD progression by the standard of care like the BP control with RAS blockade, using SGLT2 inhibitor as is appropriate, because that is one of the therapies which have been incorporated recently, preventing AKI by giving the appropriate drugs which are not nephrotoxic, and looking at the dyslipidemia, which is commonly associated with the use of high-dose prednisolone. The use of this GNR analog or sperm oocyte preservation is also a part of therapy in people who want to become pregnant in future when they are getting cyclophosphamide. But cyclophosphamide dose should never be exceeding 36 grams. Ultraviolet light exposure has to be reduced. They have to use umbrella when going in the daytime, or use appropriate screen that for the facial screen, that is the sun protective factor more than 40, to treat the bone density and fracture risk, and vaccinate the patient, because that is also a thing which kills the patient because of infection. Class 1 to class 5 lupus nephritis is treated in a different way. We do not treat class 1 and class 2 lupus nephritis with high dose of any immunosuppression. But a person with class 1 and class 2 lupus nephritis, if they are having nephrotic syndrome, we should evaluate for lupus podocytopathy, which is a disease which mimics like a minimal change disease, which has to be treated with corticosteroid with or without CNIs. The treatment of class 3, class 4, and class 5 is basically similar. That is a combination of glucocorticoid with either MMF or low-dose cyclophosphamide IV, belimumab, or a combination of these therapies, including CNI like voclosporin, which is the recent CNI, which is still not available in India. Maintenance therapy, it is said that we should maintain the patient who is in remission with MMF for 3 years, and azathioprine is only to be used as maintenance therapy if the person is trying for pregnancy. Triple immunosuppression can also be utilized, like belimumab or CNI, if person requires this therapy to reduce the kind of steroid-related toxicity. Relapse of lupus nephritis has to be treated in the same line as the basic disease. The term resistant lupus is still not fully understood. It is said that the disease is not getting controlled after 6 to 12 months of therapy. That is called resistant lupus. But before we make a diagnosis of resistant lupus, we should verify the adherence to treatment, ensure adequate dosing of the drugs before we say it is drug resistant. We may need to repeat a biopsy to see that the resistant lupus, is it already a kind of burnt out lupus with chronicity, or there is some other diagnosis which is why the treatment is not responding. If the person is active, one has to switch to other therapy which have not been tried, like persons who are not received rituximab or biologicals, that will be tried, or extended dose of IV cyclophosphamide, or patient has to be part of some trial in case they are not responding to therapy. Pregnancy in lupus nephritis is to be avoided till the lupus nephritis is inactive for 6 months, because this is a common concern in people who are having lupus nephritis young age. This one need to continue hydroxychloroquine throughout the pregnancy, with aspirin to be started within 4 months of pregnancy. Steroid and azathioprine can be utilized if required, and kidney failure and lupus nephritis will require a usual kind of dialysis followed by transplant as is appropriate. So that was the KDIGO guideline of 2024. So this is a slide, kind of maybe a visual slide to just what we talked about. The class 1, class 2, class 3, class 4 is treated a bit differently. But the basic things are that we need to combine the kidney protective measures of BP control with RAS blockade, SCQ, with other therapies that we talked about, steroid in low dose, cyclophosphamide, MMF, and other therapies, which is called multi-targeted therapy, or using tacrolimus or cyclosporine, or a BLIS-based therapy, or belimumab, which is also a part of therapy in the recent times. The refractory disease always requires assessment of adherence, because one of the common reasons for the disease not acting is using patient not complying with the therapy. So this is just to highlight the point that how the management dosing has changed over the time. In 2012, higher dose of methylprednisolone was utilized to control the disease activity in the initiation of 0.5 to 1 gram. And now we talk about 0.25 to 0.5 gram of methylprednisolone therapy for disease activity in class 3 or class 4. And cyclophosphamide earlier we used to give a higher dose based on the NIH criteria of 0.5 to 1 gram per meter square. But now people talk about 500 milligram of only cyclophosphamide to be given every 2 weeks in case we are not using oral mycophenolate. So the dose of mycophenolate is 2 to 3 grams. We commonly employ 2 gram dose in the initiation and maybe 1 gram in the follow-up when the disease is inactive. So duration of immunosuppression or cessation is also an important concept. And at the moment, this is a gray area. Optimum immunosuppressive drug tapering and withdrawal is still crucial for reducing the risk of SLE flare and relapse. Discontinuation or switching from MMF to less potent drug like azathioprine or calcium inhibitor early has been known to be associated with increased renal response and carries twofold increased risk of subsequent failure if it is done within 2 years. And hence, 3 years is the guideline to discontinue the drug at the moment. It is said that patients who are having non-renal lupus, 2 to 3 years will be the duration of therapy before we recommend the drug to be discontinued. And 5 to 7 years is the optimal therapy in lupus nephritis as per the other guidelines from Canada. Though the KDIGO guidelines say at least 3 years is the duration of therapy for discontinuation. So when we talk about what is new in this domain of lupus treatment, that approach is now being tempered with different ideas. We are not talking about cytokine targeted therapy, that is a therapy which is looking at cytokine, the anti-interleukin 1 monoclonal antibody like anifrolumab. This is now being explored, and this has been found to have positive results in the recent trials. B-cell depletion therapy like rituximab, or the other generation of B-cell therapy, the monoclonals like obinutuzumab, ofatumumab, and ocrelizumab. Anti-B-cell activation therapy, that's the BAF therapy, the belimumab, and other drugs which are acting at the same pathway. Co-stimulatory blockade like iscalimab, or anti-plasma cell therapy like botitumab or ixazomib. Other complement targets are also being explored, or the tyrosine kinase targets, or CD6 monoclonal antibody like itolizumab. So these are the areas of newer research where the target therapies are being looked at. And at this moment, these therapies are still experimental. What is shown in this slide is that because of the dysregulated this cell death, apoptosis, dysregulated apoptosis because of various regions, including viral infection, the nucleic acid which is released can activate the dendritic cells, and which, as a kind of downstream kind of signaling of various pathways, can produce an auto antibody which is detrimental and which can be blocked at different levels as shown in this slide, at the level of B cell, at the level of T cell, at the level of CD20, or at the level of BAF, or at the level of plasma cell. So these are the areas which are at the level of tyrosine kinase inhibitor. So these are being explored, and at this time, this is a slide which summarizes that what are the areas which have been found to be useful. Like in the Aurora trial, it was found that patients who are on voclosporin was found to have a better kind of response. Similarly, the seculizumab, which is acting at the level of interleukin-17A, is found to have a kind of positive report. The Nobility trial have found that this obinutuzumab, which is a drug which is similar to the rituximab, was found to be useful. Belimumab, which is acting at the level of Bliss factor, is also found to be useful. And similarly, anifrolumab that we talked about, the type 1 interferon, which is released after the activation of this primed dendritic cell, was found to be a kind of positive trial. So there are various areas of trials which have been shown in the slide, which is a newer therapy for lupus nephritis and has been approved by FDA, but has not been yet incorporated in the day-to-day practice of lupus nephritis. CAR therapy, that is a therapy which is utilized, which was earlier utilized for treating various kinds of malignancies, is now being talked about in the context of treating resistant lupus, where the patients this leukocytes are separated, and by genetic engineering they insert certain genes which ultimately tries to kill the cells which are toxic for the body, and thereby it tries to control the disease. And this anti-CD19 CAR T cell therapy was found to be efficacious and tolerable in patients who were refractory to SLE, being now explored in the context of resistant lupus. And this is a therapy which can be utilized in a kind of in a kind of experimental setting, as well as in the lupus trial setting, where these patients are not responding to therapy. So this is a kind of incorporation of ideas from treating malignancies. Bliss therapy, this is just a cartoon to show that what has been found in this trial, that when the patients were added belimumab to standard therapy, it improved the kidney outcome in patients with lupus nephritis. So this could be a triple drug combination, like we are using steroid, we are using MMF and belimumab to control the disease activity and quickly reduce the steroid dose. Aurora trial, the voclosporin was found superior to placebo for treatment of lupus nephritis, and it was concluded that voclosporin compared to placebo in combination MMF and low-dose steroid is useful, and this could be a kind of CNI which may be utilized more often in SLE compared to the tacrolimus or CNI that we are being using. So this is just to highlight the point that SLE is still a disease which is evolving over time, with the treatment options which are changing, and there are various trials which are there based on which the recommendations have come. And we are looking for newer trials which will be a kind of targeted trials for precision medicine in the patient of SLE. So if we look at the drug therapy of the past, we were using methotrexate, azathioprine, leflunomide, mycophenolate mofetil, cyclophosphamide, tacrolimus, cyclosporine, rituximab, and belimumab earlier for skin, but now also for the kidney. The newer treatment options which are part of recent therapies are voclosporin, anifrolumab, CAR therapy, and other rituximab-like therapies in patients of SLE, like obinutuzumab. So to come to the last few slides, newer drugs which are now approved in the last 3 to 4 years. Belimumab has been approved for lupus nephritis in 2020. Earlier, it was approved for skin disease in for SLE. Voclosporin, a novel oral calcineurin inhibitor, has been approved for lupus nephritis in January 2021. And anifrolumab, an anti-interferon alpha monoclonal antibody, was approved for moderate to severe SLE in August 2021, making it the only new drug in SLE over a decade. So despite understanding the autoimmune process in SLE, still we are far from clear and far from reaching the goal of precision medicine. So when should we use biological is a moot point. Like now we are having more and more biologicals. It has to be explored in the trials. Early initiation of biological therapy may achieve better response and reduce the corticosteroid toxicity. And it is believed that after conventional treatment, if the disease is not well controlled within 3 to 6 months, biological therapy should be considered. So to conclude, organ damage in SLE has a considerable impact on mortality and the quality of life. Treatment goal is not only to control the disease, but also to minimize the long-term consequences of organ damage and the drug toxicity. One may be able to avoid corticosteroid-related damage with the use of other steroid-sparing drugs like the biologicals that we talked about, belimumab. While some of the patients do quite well with SLE, there are many others who do not do well because of disease or the drugs. Using existing medication better by employing appropriate therapeutic strategies such as treating to target and looking at the patient individually with the recent investigation facilities will be the way to go forward. Despite advances in treatment, a significant proportion of SLE patient is prone to manifest one or more disease exacerbation, which incur in significant burden and may impact adversely on the long-term outcome. The risk is particularly higher in context of continuous uncontrolled serological clinical disease activity, especially for major organs. Apart from targeting the low disease activity or remission, by physicians who are looking after SLE patients should therefore consider strategies for preventing disease activity exacerbation, particularly maintaining an effective immunosuppressive dose and biological therapies which are well tolerated. For future, we are eagerly awaiting the establishment of good biomarkers to predict the disease activity worsening over time and enabling the treatment, which is precise treatment for such patient. Thank you all. I conclude my talk, and if there are any questions, I'm willing to take up. Thank you.
Thank you, Dr. Jha.
Thank you.
I would like to open the question answers on the floor.
Yeah.
Dr. Monica, would you like to say something?
Sure. I just wanted to say thank you for a fantastic presentation and a review of the current state of lupus nephritis. I think this is very important for everybody to recognize because of the high prevalence of the involvement of the kidney with patients who have lupus. I think that there's a need for always to refer these patients to make sure that we're catching the disease early and that we have your type of expertise always involved in these cases to be able to protect their kidney function and to prevent the progression of their disease. So thank you very much for a great presentation.
Thank you.
Dr. Chong, are you present?
Yes.
I think he might have a patient. Dr. Chong?
Yes. Oh, Dr. Chiang, you say.
Yeah.
Hi, I'm sorry. I'm with a patient at the moment, so I've got to excuse me for a minute.
Yes.
Thank you very much, Dr. Jha. I listened to part of it just now, and it was excellent. The lupus nephritis is something that we're always kind of worried about. And SLE, we do see a lot of SLE in Singapore. In particular, we see a lot of it in our young Chinese women, teenagers, in fact, and it's a horrendous disease. So we have some really bad SLE lupus in young Chinese women here in Singapore. It's very devastating. We've seen quite a lot of these cases, and quite a number of them end up in dialysis or, cyclophosphamide for 12 months, or eventually some of them perish too. I recall one of my classmates in medical school, young Chinese girl in 3rd year of medical school with severe lupus, and she died on us. So yeah, lupus nephritis is something that we are always very worried about and very, very careful about in Singapore, because we have a particularly bad disease in a subpopulation of our people here. Thank you. Sorry, excuse me. I got to go see the patient now. Thank you very much.
Thank
you. It might be missed. I don't think you need to miss it at any of the disease. Dr. Angelica, you want to say something more?
Yeah, thank you. It was very interesting to sit and listen. I was trying to think, have I ever seen an SLE nephritis? And I can't bring anything to mind. So only two possibilities. We either miss it big time here in general practice, but I also I'm trying to think, we don't have a lot of SLE patients in the general day-to-day patients that we are seeing. But I will from now on make sure that I don't, double check on alopecia and a bit of dermatitis or skin lesions, that I don't miss it. But this is not something that is that common in the South African context in primary healthcare where we practice. Thanks.
Thank you, everyone. I don't see any more questions on the floor, so we would like to wind up this session in the interest of the time for the doctors.
Yeah.
Dr. Jha, thank you so much. Dr. Ravi, do you want to say something? You unmuted?
No, nothing. Thank you.
Okay. So, we would like to wind the session. Thank you, Dr. Ratan Jha,
Thank you.
for your wonderful, insightful information on this topic. We would like to have you invited for many, many more forums. Thank you for your time, and everyone else, thank you for joining. Stay tuned.
Thank you.
Thank you.
Thank you. Thank you.